And good evening and welcome to all of you who are watching our online panel discussion. It's the first of the year from the Foreign Correspondents Club of Thailand. And we are, in effect, back in a sort of semi-lockdown and doing what we did last year and running our events online while anti-COVID restrictions are in place. The club itself is still open. You can pop in there during the day or in the evening for a meal. We can't serve alcohol at the moment, but it's a big club with lots of space, so you can manage some pretty effective social distancing. So if you are in the center of Bangkok and you want to call in, you will find a warm welcome there. Of course, we look forward to having our events back in the club again when we can. A great deal depends on the effectiveness of the measures that the Thai government is now imposing, and of course the cooperation of the Thai public. Last year, Thailand, I think, surprised everyone with the extremely effective way in which it managed to contain the first COVID-19 outbreak and ended up by about the middle of the year in the enviable position of having very few local infections and having more or less got the pandemic under control here. Very few other countries matched that record, which allowed a great deal of domestic life to resume, albeit at huge cost to the international tourist economy. At the time, I think many people in Thailand hoped that they could maintain that, but we have seen another outbreak in the last few weeks that has brought daily infection numbers into the hundreds, rather higher than they were last year. And we will have to see whether those measures, those anti-COVID measures, work as well as they did last year. Thailand, of course, and this region are in nowhere near as difficult a state as countries like the United States, Britain, India, Brazil. These countries have got much bigger pandemics. But all these countries are facing a situation where they are trying to balance the damage done to the economy with the need to stop the coronavirus transmitting, and pinning their hopes right now on the very speedy development of vaccines. And this is the great hope of this year. It's what everyone's looking forward to. Governments across the region are frantically making contracts with vaccine providers to get as many doses as they can and planning their rollouts. And it varies a great deal from country to country. I see that in Indonesia, President Joko Widodo has been vaccinated today with the Chinese vaccine. They're planning a very big rollout there. What about Thailand, though? This country, I think last year, there was a sense that perhaps a vaccine wasn't quite such an urgent need given the lack of COVID infections here. And Thailand itself, the Thai government, has put quite a lot of work into developing or supporting the development of a local vaccine. They've also got a contract with the British-Swedish drug maker AstraZeneca, which is producing one of the best known of the COVID vaccines, to manufacture it locally here by a little known company known as Siam Bioscience. At the end of last year, Thailand agreed to buy 26 million doses of the AstraZeneca vaccine. But in the last few weeks, we have seen the government trying to get other supplies as well as it builds up its vaccine numbers in the event that this particular outbreak isn't controlled. And I think with the realization that every country now has to have a vaccine rollout. Never before, I think, has a vaccine for an entirely new illness been developed with this speed. Obviously, given the stakes, there was enormous pressure on drug companies to do this. We're joined tonight by two very distinguished speakers who can both look at the international situation and the situation in Thailand. We're very privileged to have Dr. Lorenz von Seidlein, who is an associate professor at the Mahidol Oxford Research Unit for Tropical Medicine, who's a very experienced epidemiologist, done a lot of work on the development of vaccines for malaria. And we're very grateful to Dr. Nakhon Premsri, who's the director of Thailand's Vaccine Institute, because that is it's his people who are really looking at the development of a vaccine. The National Vaccine Institute has been working for a long time on developing vaccines to illnesses that have affected Thailand. This country has done a lot of work and research into vaccines. This is now, of course, a huge challenge dealing with the coronavirus. So Dr. Nakhon can talk to us about how Thailand has evolved its vaccine strategy since last year, and in particular, the work that's been done to try to build up vaccine manufacturing capabilities and indeed even developing original vaccines here in Thailand. But I'm going to start this evening by asking you, Dr. Lorenz, to give us an overview of the vaccine development for COVID and the sorts of challenges that poses.
Okay, thanks, Jonathan, very much for inviting me. Can I go to my slides, or is that okay? Yeah, thank you. So in the right upper corner, unfortunately, I think I don't have a pointer. In the right upper corner, it shows you kind of the idea how vaccines should be evaluated. And we are in the lucky position that there are about 100 vaccines already in development. These vaccines should go first through a phase 1 trial, which is kind of a small number where you just see whether the vaccine is safe. Then it goes into a phase 2 trial where we check whether the vaccine is safe and has some immunogenicity. And from there, it should go into a phase 3 trial where we check the safety, the immunogenicity, and the protective efficacy. How well does this vaccine protect people? And then based on the results from the phase 3 trial, the vaccine gets an approval, either a full approval or a conditional limited approval initially. And I have selected here 8 of the 10 vaccines which have this approval at the moment, starting out with the Pfizer BioNTech vaccine. That's an mRNA vaccine, and that means that there is a set of instructions in the form of nucleic acids injected, and that is taken up in the cell, translated into a protein, and then the body triggers immune response against these proteins. And this vaccine was evaluated in the United States and other countries, and the estimated protection is about 95%. This vaccine has received approval in the United States, in the United Kingdom, and in the European Union, and a couple of other countries, which I'm showing here on this slide. The second vaccine is Moderna. It's also an mRNA vaccine. It has a very similar characteristics, and also kind of the similar protection of 95%. This also already been licensed in the United States, United Kingdom, and the European Union. And then we come to the AstraZeneca vaccine, that's also known as the Oxford vaccine. And this uses a little bit of a different platform. Here, the genetic material is spliced into a harmless adenovirus, and that is injected and then translated into a protein, and the body again forms an immune response to this protein. Here, the protection is a bit controversial. I listed here 62% protection, and this is the estimated protection that was used for the licensing. So the regulators have based their licenses on the 62%. But there was a subgroup of people who were vaccinated accidentally with a half dose first and then with a full dose, and they had a much higher protection, like 90%. However, this subgroup were healthy young people, and it stands to reason that healthy young people mount a better immune response than older people and sick people. The AstraZeneca vaccine is approved in the United Kingdom and India, in addition of a couple of other countries. Here, the really important point is the strength of that vaccine is that it is cheap and it can be stored in a refrigerator between 0 and 8 degrees. In contrast, the mRNA vaccines on top of it, they have to be stored in a freezer. In the case of the Pfizer vaccine, the freezer has to have minus 70 degrees. And the sad fact is that in many countries where there is COVID pandemic, which is around the world, there is not a sufficient capacity of minus 70 freezers to store this vaccine. So there is a need to use other vaccines, and we cannot rely only on the mRNA vaccines. For the regulators, it's a massive problem, and this vaccine has not been approved yet in the United States and in the United Kingdom. And one of the problems is not only that the file is very complicated due to this accidental use of the half dose first and then the full dose. The other problem is if you have already 2 vaccines with 95%, and then you want to approve one with 62%, who is going to get the 62% one and who is going to get the one with 95% protection? That is a problem, how to deal with this. So that's these first 3 vaccines that we are having. And as you said, it was very unusual how quickly these vaccines were developed. And could be rolled out already. Until last year, the fastest vaccine that was ever licensed and developed was a mumps vaccine in the 1960s. And the developer, Maurice Hillman, found that his daughter had mumps, and he realized that in the morning, took a swab, and then 4 years later, he had a vaccine. That's the Geraldine mumps vaccine, which is still being used. But then you have, on the other hand, for example, HIV/AIDS, and you may want to remember that these 40 years, nearly 40 years later, we still don't have a vaccine against HIV/AIDS. So there was a certain amount of skepsis at the beginning of last year, how long it would take to develop a vaccine. And I think what we have at the moment is far beyond our hopes, that we are really have vaccines available with 95% protection, which seem to be really safe. So that is quite an achievement. And it immediately leads then to the question, where are corners cut? How is that possible? And to give you the short answer first, no, there were no corners cut with these 3 vaccines at least. That's for sure. The technology was in the waiting. DARPA had financed mRNA vaccines for more than a decade. The vectored vaccines have been used previously, for example, for the Ebola vaccine that uses the similar platform. So the technologies were not completely new. The second thing is there was a pandemic. That means there were a lot of people volunteering for a case. And then when they participated in the trial, it took only a relatively short time to accumulate enough cases to estimate the protective efficacy. That's 2 important things. Then everybody involved in these trials really wanted to get them done in the shortest possible time. So the gap between phase 1 to phase 2, and then from phase 2 to phase 3, that can take months and years if people are not particularly motivated to move forward. And in this case, basically the phase 2 for these trials started immediately, if not before the phase 1 was already finished. And then the same happened for the phase 3. And most importantly, the regulators were really involved during the whole process. Usually you have to finish your phase 3 trial, prepare a perfect dossier, submit this, and then a couple of months later or even years later, you receive your approval. In this case, that was a rolling process. So the regulators had the phase 1 data, the phase 2 trial data, and so on, and they could very, very quickly give the approval virtually within a week, within days after the phase 3 trials were completed. So that's completely unheard of. And it raises the question, why isn't it not done for other vaccines? Why was that not the case for the Ebola vaccine? Why was so much time basically wasted? And I think it will set a standard for the future, or at least I hope it will do. But let's talk also about the other 5 vaccines on the list there. The first of that is Gamaleya. That's the Russian vaccine, and it is also a vectored vaccine. And that the vaccine producers released kind of their protective efficacy estimate within days of the Pfizer BioNTech. And so since Pfizer BioNTech said 95%, they said 92%. And that was it. But they did not release the data from the phase 3 trial. What we would like to see is kind of a peer-reviewed report in a peer-reviewed journal. And that was definitely not the case for the Gamaleya vaccine. The next one is then CanSino. It also uses this vector platform, and they have not provided any estimate of the protection. And then we come to Sinovac, Sinopharma, and Bharat, and they use a different platform. They use killed vaccines, and that is exactly what it does. You grow the virus or the bacteria, whatever you base your vaccine on, in culture in very large amounts, and then inactivate it using either heat or a chemical like formaldehyde, which kills these organisms, and then they are processed into a vaccine. Sinovac is, of course, very interesting because, as you just mentioned, the Indonesian pandemic response is very much based on this Sinovac vaccine now. And so it is very critical for everybody. And last week, there were estimates released that it had 78% protective efficacy. And then yesterday, Butantan had a press conference where they said, well, it's actually only 50.4%. And I understand that this morning there were reports in Shanghai in China released where the vaccine producer Sinovac said, well, actually our vaccine is 100% protective against severe disease. And that is pretty characteristic for these 5 vaccines, is that we don't have reasonable data on which we can base our own judgment and decide what we want to believe. We are basically here forced entirely to believe the drug producer, that if they say it's 78%, well, that's all we have. And that's a little bit unfortunate. Then we have Sinopharm, which has done a vaccine trial in the United Arab Emirates. And that was the estimated protective efficacy in that trial was 79%. So that's quite reliable. But again, they haven't published the trial, which is annoying. And then we have Bharat vaccine, which is a massive producer in India. And so they are important, and they have done a phase 3 trial, or are doing it at the moment, but we have not seen any reports from that trial. So again, we have no data. So that is the situation of the vaccine development at the moment. Let me see whether that works. Excellent. And as of January 11th, a total of 24 million doses, vaccine doses, have already been administered. Out of these 24 million doses, 9 million doses are apparently this Pfizer vaccine. And that is really reassuring, because there were a number of adverse events, but no really convincing severe adverse events attributable to this vaccine after 9 million doses. And that is deeply reassuring, more reassuring than any trial, any phase 3 trial, basically. There were a couple of cases of anaphylaxis, and perhaps more than expected, more cases of anaphylaxis. And some of the vaccine scientists said that is probably related to the PGE in this vaccine, which triggers anaphylaxis in some cases. But these anaphylaxis cases are still very rare events, and none of them have been lethal. Some people had to stay overnight in the hospital, but most of them could be treated on an outpatient basis and could leave the vaccine centers very quickly. So here you have the list of the vaccine doses administered so far. And then I would like to go to what kind of doses have to be distributed, what kind of vaccine coverage do we have to reach to interrupt the transmission, to terminate this pandemic. And that is a little bit difficult, so just bear with me. The vaccine coverage required to provide community protection, also known as herd immunity, is 1 minus 1 over R0. And again, bear with me, R0 is, or R0, is the basic reproductive number, which is the expected number of cases directly generated by one case in a population where all individuals are susceptible to infection. So a completely naive population. And the R0 for the R0 for COVID, the estimates are a range basically. And again, this is in a completely naive population we are talking here. So before Christmas, we were talking about kind of R0 between 2 and 3. And if you plug the 3 into the formula that I have up there, then the vaccine coverage required to interrupt transmission would be 66%. We have since heard that there are these variants, and they are more transmissible. They are not more dangerous. They are not more pathogenic. They don't cause more severe disease, but they are increase the R0 from perhaps 3 to perhaps 4. And that would mean that the vaccine coverage required to interrupt transmission is as high as 75%. And that is very difficult to reach. Sorry, here, 1 second. If you if you have an entire population, and at the moment, we are only vaccinating old people, and then we want to go into adults. But at least a quarter of the population are children in most places, between 20 and 25% of the population. And currently, there is absolutely no evidence how these vaccines, any of these vaccines, work in children. So if you don't vaccinate the children, then your population is you only vaccinate 75% of your population. And if you then use a vaccine which is not 100% protective, you have reduced the effective coverage again. And then you have vaccine hesitancy. Not everybody who is offered the vaccine is taking it. Even, for example, old people in the United Kingdom who are now offered the vaccine, they are called up and asked. About 1 in 5 says, no, thank you, I'm not interested. I wait a little bit longer, or maybe I don't take it at all. So if you take this into consideration and you have a coverage of say 70%, and you have a vaccine which is 70% protective, then it's 0.7 times 0.7, which is kind of a little bit less than 50% effective coverage, which will not be enough to interrupt transmission, unfortunately. So under these circumstances, it will be necessary to continue with other measures like wearing masks, social distancing. This will be absolutely essential, even when the vaccine rollout starts. Earlier today, the government of New Zealand and Australia has stopped the rollout of the AstraZeneca vaccine for that reason, because they feel there is an opportunity loss if they use a vaccine which is only 62% protective, and would like to replace this with a vaccine which is more protective. So they are shifting towards one of the mRNA vaccines, and want to use that for their rollout to reach the highest possible effective coverage, and use the vaccine to interrupt transmission. So that's one process that is ongoing. Another idea is, why don't we just use vaccinate, give everybody the first dose, and then at a later stage give the second dose? How about that idea? And the protective efficacy after only a single dose is maybe between 50 and 60% of the mRNA vaccines. So you have reduced the protective efficacy nearly by half. And what is also very important is if you then delay the second dose, this is not perfect vaccine protection. So it decreases over time, it goes down. And that is worrying, obviously, if the vaccine protection then is maybe less than 50% or something like this. So what we would really like to see is that everybody, if in any way possible, gets the second dose as quickly as possible. In the United States, Joe Biden's incoming administration has said that they want to roll out every vaccine that is available and then see how to procure the second dose. And I think that has been taken up this week in the United States. So the idea is just to roll out, but not necessarily, or not try to delay it any further than is necessary. If it has to be delayed, the important rule there is with our children's vaccine is that you can continue a series. So you give the second dose, you don't have to start all over again. So you don't have to give 3 doses, you just give the second dose. But it would be really helpful if that could be done as early as possible. So what has been achieved in terms of coverage at the moment? And the leader in vaccine coverage is Israel, which at the beginning of this week has managed to vaccinate about 21% of the population. How have they done this in Israel? They have a huge advantage in that they have a functioning healthcare system, which is always a really good starter. They have experience with mass vaccinations campaigns in the past. They have a relatively united community, which is highly motivated, and relatively high vaccine acceptance in the country. Then if you look down here, United States has only achieved by 8th of January 2% coverage of the entire population. And in the United States, they start out with targeting only people over 80 years of age and essential healthcare workers. The United States does not have a really functioning healthcare system. There's a highly divided community at the moment. So if you're in one group, then you're basically going to refuse to have a vaccine, and if you're in the other group, you are fully for it. But if only half the population is willing to think about vaccines and think about participating, you're not going to reach the coverage necessary to interrupt transmission. That has to be clear. They really have to find more appropriate ways very quickly how to administer vaccines. But very interesting here at the bottom, you see France with only 0.1%. Here, Italy, the neighboring country, has 1% coverage achieved, and France only 0.1%. And why is that? Because in France, there is a hell of a lot of vaccine hesitancy. People are not very fond of vaccines there. And so the government has asked people to come to the general practitioners, talk to a professional healthcare worker, a competent healthcare worker. And everybody has the right to speak to a healthcare worker to address all the concerns and explain the vaccine before the vaccination. That is, of course, very caring and kind to the people who get the vaccine. But if you want to have massive coverage of your entire population, you're not going to get there with that way. So let me remind you here of an old slide. This is from 1962, when the polio vaccine was rolled out, in this example in San Antonio, Texas. And people are queuing around the city auditorium, which you can't see here because of the aerial view, but people basically queue around the whole block, and in expectation that they get their polio vaccine. In New York, 5 million people were vaccinated within 14 days against polio in the 1960s. But we are having here new vaccines, and it's maybe not such a bad thing to start a slow rollout, particularly to address these concerns and vaccine hesitancy. It might be a good idea to be slowly ramping up, basically. But if you desire ultimately to have high coverage, 70, 80%, you really have to follow the Israel model, where they set up tents and you basically get your invitation either by mail or by email or by text, and then you go there. They are first targeting people over 60 years in Israel, and then if at the end of the day people have not shown up, anybody can come and get vaccines and do this in the most effective way. Of course, these polio rollouts is more than half of a century ago, and we have to learn this again, how to do mass vaccination campaigns in the best way. And that has to evolve very, very quickly if we want to make inroads with vaccines. So let me just talk quickly about some the major issues in the rich countries. It's now logistics and vaccine hesitancy. Some people say it is vaccine supply. Politicians particularly go for the thesis that the reason why it's not really working is the vaccine supply, and the vaccine suppliers, the vaccine producers, say it's absolutely not true. We are ahead of schedule. You can have as much vaccine as you want to. So that's kind of different information coming from different people. In more poor countries, the problem is there are no vaccines. There's no vaccine supply at all. So we have to get to the point to bring vaccine to poor countries, not only because we are bleeding hearts. The problem is if in poor countries there are still reservoirs of this infection, and basically anybody who travels from that country, who lives in a country, comes to another country, will restart an outbreak in no time. And if you say, okay, we build a wall around our country and don't let any people in, it's only a question of time when people from your country are going to travel into this country and bring the vaccine back home. Maybe not you, but your children will do that. So to reach a point where we are safe, we cannot exclude certain countries and ignore them. We have to be very early on. We have to roll out vaccine globally. And then another big concern that is coming up now is mutant vaccine strains, variants as we call them. And the question is there, what is the risk of these variants to escape vaccine protection? Yesterday there was a WHO consultation, and they came basically to the conclusion, the more you look, the more variants you find. So the early variants were found, that is due that these countries are intensely looking for it. In the United Kingdom, for example, there are more than 7,000 vaccine strains have been sequenced. In Denmark, also very high numbers. In Germany, the number is 5 strains which have been sequenced. So obviously, you have a much higher chance to find a variant in the United Kingdom. Pfizer BioNTech have very early on said that this is not an issue, this new variant, which we call N501Y. And last week there was a release of a preprint from the University of Galveston in Texas, where they took sera from people who are vaccinated with the BioNTech vaccine, and then used it to neutralize these N501Y strains. So that is working. There is no question. The Pfizer BioNTech vaccine and probably the other vaccines as well protect against this particular strain. Now, the BioNTech founder and chief scientist has already assured that their vaccine can be reformulated within 2 weeks and rolled out. But then the question is, you have a new vaccine basically. So how do you get the regulatory approval for such a new vaccine in a really short time? And there is a model, because the influenza vaccine strains are changing very quickly. And so there is basically a new influenza vaccine every year. And there is already a regulatory mechanism for a platform which is known and has been approved, how you can vary that a little bit. But that still leaves us with a really big question, that if there are already so many variants around, and now you add an evolutionary pressure to that in the form of a vaccine, how quickly will these vaccine mutants take over? So it is a reasonable concern to think about. And I think we already have a kind of a plan how we will address this in the future. So before closing, I would just like to say, end up on a positive note, basically, is that this last year was really transformative for a lot of people, particularly young people. And we have seen this development of new biotechnologies, particularly I'm thinking here of the mRNA technology, which was for me a really huge surprise last year, that would work so well. And I predict that many young people have been heavily influenced by the last year, and will now become much more interested in working in healthcare and biosciences, compared to, say, financial services and the financial service industry, which was so much more attractive in the previous years. And the other really important aspect is also that I think there are not many politicians who have missed the signal that the pandemic and not some war has felt the president of the United States, and that has consequences. So there will be a redistribution of funding. I'm really sure about this, and there will be a much higher priority for healthcare and for biosciences in the coming decade. And I think that's a really positive development that's coming out of that. All right.
Thank you very much, Lawrence. I'm glad you got a positive note in there. It was looking a bit gloomy on the efficacy of vaccines. I think we've all got to be a little bit more sober in our expectations as to what vaccines can do. I'd like now to bring in Dr. Nakhon Premsri and look at the situation here in Thailand. And perhaps, Dr. Nakhon, you could just, you've got things you need to tell us, but I think everyone's fascinated to know how Thailand has formulated its vaccine strategy over the past year.
Well, yes, I think we can start with at the very beginning of the outbreak, and then Thailand we respond to the outbreak in two kind of things. The first, that we conduct a large intervention on the prevention and control, and the second thing is about the virus study, the virology. We can do a kind of genome sequencing of the virus early in January, after the first case of Chinese tourists, and then by then we can isolate the virus by the Department of Medical Science of the Ministry of Public Health. So those things on the genome sequencing and the virus isolation led us to think about develop the vaccine by ourselves. So we start in February to collect the effort from the university and the institutes in Thailand, including the private sector, to join together and discuss on the brainstorming of how can we move on local vaccine R&D. And that part we discussed together, and we see the opportunity that we can develop ourselves by the vaccine. Even we have a limited capacity on the vaccine R&D, and then we start from there. And in the policy perspective, we developed what we call a blueprint of COVID-19 vaccine access for Thai people. Then we have three approaches that we developed by the policy. The first approach is we conduct our local R&D study, moving forward for vaccine development and aiming for the vaccine manufacturing. And the second approach is trying to find on the international collaboration and look for the technology collaboration and transfer. And the third part we keep as the third part, that's in a way of vaccine procurement or vaccine sourcing and procurement for the vaccine from the international developer of the vaccine. So we use those three strategies to build up our activity over here. We've got support from the government on the local R&D for a number of researchers over here, such as the mRNA vaccine by Chulalongkorn University, and the DNA vaccine by the Bionet Asia, the private company, and the subunit protein developed by the plant-based vaccine manufacturing by the Faculty of Pharmacy in Chulalongkorn University, and the startup company, what we call Bayer Phytopharm. So those are the lead candidates that we have had in hand, waiting for the human trial in this year. We've got a very good result in animal testing. And the rest of the candidates we still have in hand, like a viral vector, adenovirus vector developed by the biotech of NASDA, the National Science and Technology Development Agency. And the government pharmaceutical organization is collaborating with PATH organization and the Gates Foundation in doing a kind of a Newcastle disease virus base of a COVID-19 vaccine. So those are the kind of examples that we develop ourselves in hand, but so far it's still be in the animal stage. So move to the second strategies on the collaboration. At the very beginning, we connect with our international partners, and we're aiming for to bring the vaccine to be tested in Thailand during the situation of the first wave of the outbreak. But when we've got a very good control of the outbreak in Thailand, so I can tell that the attraction to conduct a clinical trial in Thailand was lowered by the control of the outbreak, meaning that we were not a suitable place to conduct a phase 3 trial. So we still keep on that collaboration on exchanging of the information, and kind of still have a kind of information regarding the human trial phase 1 and phase 2. Keep monitoring if there is an opportunity of collaboration with international partners. So, and then by around July last year, there was a kind of good collaboration work between the SCG group and Oxford University, and introduced us to the AstraZeneca company during the kind of policy of expansion of global supply by the company AstraZeneca. So AstraZeneca conduct in a kind of due diligence and kind of checking on the capacity of our local partner named Siam Bioscience, which is a uh, a biotech company. They they were producing what we call the erythropoietin that used in the chronic renal failure patient. Uh, it was established 10 years ago, aiming for only the kind of uh, protein and biosimilar manufacturing. But when AstraZeneca evaluated the capacity and the potential of Siam Bioscience, they found that it's in a good status, a suitable status that can repurpose the factory and the manufacturing capacity, which we have a large bioreactor in the volume of around 2,000 liters, and estimated that we can produce a number of vaccine in around 180 to 200 million doses of vaccine. So that lead to the collaboration between AstraZeneca and Siam Bioscience, and bring to the collaboration with the Ministry of Public Health and NVI and the National Vaccine Institute on the way of one arm is a technology transfer, another arm is a kind of vaccine access that we did advanced market commitment with AstraZeneca to support two things, meaning that the government will buy the vaccine that will be manufactured by Siam Bioscience under the control of quality and standard from Oxford University and AstraZeneca. Uh, and Siam Bioscience will be in a kind of one of the supply chain equal to Serum Institute of India, that another supply chain of AstraZeneca vaccine. So that brought to a collaboration in a way of technology transfer of a viral vector vaccine of AstraZeneca, and we can see that the capacity right now, we are pretty confident that Siam Bioscience can produce a vaccine according to the standard indicated by Oxford University and AstraZeneca, and we are waiting for a batch of the vaccine to be inspected and checked of the quality by the Thai FDA and Ministry of Public Health, and including the Department of Medical Science on what release. So we will wait until we've got consistency of 5 batch of manufacturing, and we hope that three among 5 in the quality of the batch of the vaccine that will be produced. Actually, it has started off the technology transfer last year in the mid of December. Siam Bioscience told us that they got let's say 1 milliliter of vaccine seed containing a virus, and they need to scale up of that 1 milliliter vaccine to be 2,000 liters of vaccine, and that required around 4 months each batch. So that we hope that by the maybe late in May, we've got 3 consecutive consistent of batch and quality equivalent to the standard of AstraZeneca and Oxford University, and then we can have a vaccine by then. So that's the plan on the another track of technology transfer. And then the third approach, that procuring of the vaccine, and you can see that that the late measure that we are starting the kind of conducting of procurement, and because by the timeline of AstraZeneca that we've got, we will get the vaccine by maybe late in May, so that during this kind of outbreak situation in Thailand, we may need a kind of urgent lot of vaccine to be in hand in case that we would like to use a vaccine for controlling of the outbreak. During we are waiting for the big lot from Siam Bioscience, so that we start sourcing of the vaccine that which one can deliver to us by the first quarter or maybe the beginning of the second quarter of this year. So we found that Sinovac is one of the potential manufacturer that maybe can deliver the vaccine to us by that timeline, so that we start a kind of discussion and making a kind of looking for the number of vaccine in a way on a kind of 2 million doses that to be delivered in Thailand in late February, March, and April, respectively. So that the development that we trying to get the vaccine as early as possible during we are waiting for the big lot. And the other of discussion, we have started discussion on vaccine procurement with number of manufacturers. So by maybe I can say the number that like the name that Pfizer, we are discussing with them to find more doses if possible, as well as the early doses as well. The other company, Moderna, we have talked already, but they told us that it is unlikely that we will get the vaccine in first quarter. The other company we are also in discussing with the Serum Institute and Johnson & Johnson, the potential, the other vaccine, including Sinopharm from China. So those are the approach that we are making on the strategies, try to get a vaccine for Thai people, and by the policy, we aiming for 50% of coverage of population to be vaccinated in this year, meaning that starting from May or June, and we will have 6 months of rolling out of the vaccine. We hope that half of the population in country can be vaccinated in this year, and the later maybe the additional doses that we can find more, so that we can get the more coverage of the population in the early part of next year. So I would stop here if there is any question, and please to address.
Thank you very much, Dr. Nakon. Actually, there's quite a few questions that are coming in that are appropriate for both of you. But as I've still got you focused, Dr. Nakon, there's a couple relating to Thailand. One question here is about Siam Bioscience. Nobody knows very much about this company, and it hasn't ever made a vaccine before. Do you know why it was chosen, and who chose it? Did AstraZeneca choose it, or did the Thai government recommend it as their kind of chosen place for manufacturing?
So as I think I have told, AstraZeneca evaluate the capacity of Siam Bioscience, and they select Siam Bioscience that by that reason of capacity of supply and the capacity of production that can be repurposed from maybe just from the biosimilar. They have a very experienced staff over there on the kind of cell culture, so that the capacity that can be repurposed from the protein biosimilar to be the vaccine. So it has been chosen by the AstraZeneca, but it's not just a random pick. They look at the whole factor that can be a large supply for not only Thailand, so maybe for the region as well. So that the answer.
Some people have suggested that Thailand has been slow in going to procure vaccines. If you look at Malaysia, they've procured a lot more vaccines from a greater variety of suppliers, and they're suggesting that perhaps Thailand maybe got complacent because you got COVID under control. There wasn't a big focus on vaccines last year, and you're having to race now to catch up. Is that fair?
No, it's not fair. because I think I have told already that we have a really long and continuing discussion with the international partners. I think timing is not a determinant. I think Dr. Lawrence addressed the coverage is the key of a vaccination program. So getting the vaccine first, but a very small amount, it will not have any impact on the outbreak situation. You can look at the country that have a big outbreak right now. Even they roll out the vaccine, maybe millions of doses, but the situation cannot be better. It needs time and coverage of the vaccine. So it's not about a racing by the 100 meters. It's a marathon. So we need to look at in the long term, what's the coverage of the people to be vaccinated. As well as I think Dr. Lawrence has addressed, vaccine is not a kind of magic bullet or single measure that we will use for disease control. So you cannot rely only on vaccine. So Thailand will use the vaccine, including together with our prevention and control measure that we had. So that we believe that using vaccine and our prevention and control, we can achieve in a way of controlling of the epidemic in Thailand. So I don't think that it's not a kind of a promotion or the way to do a kind of promotion that or the public announcement that who get the vaccine first or which country get the vaccine first. I think the point that Dr. Lawrence pointed out on the Israel, so that the point that we should look for the coverage of vaccine for the people, and we hope that the coverage will be distributed globally, not just one country or a few countries. So it should be distributed globally. That's one of the point that I would like to address. Another point that being rushed on the vaccine, we may need a suitable time to implement the vaccine program in the country. During this time, we will see more and more serious adverse events reported from the country who use the vaccine, so that we will get the caution when the vaccine comes to Thailand. So we will implement appropriately with the more safety profile of the vaccine. It's true that we need to rush for the vaccine, but I think the vaccine that we have in hand, and it will be equal almost or the same time with the majority of the countries of the world, that they will get the vaccine. So that I would like to address that importance of the vaccine, not just which country get the vaccine first. Over to you.
Thank you very much. Lawrence, I've got quite a few questions relating to the effectiveness of vaccines. One question is about do we know how long these vaccines confer immunity? And someone else has asked that if you're vaccinated with one kind of vaccine, would it be effective if later you took a different vaccine for either your second or third? Presumably, we're talking about people going on being vaccinated every year for quite a long time.
Can you hear me?
Yeah.
Good. For how long does it work? Well, these vaccines have only been developed last year, and the first people have been vaccinated in the last 3 months. So it's really difficult to project into the future, and nobody knows that. That's the first fact. And then, of course, you can make projections, and based on previous vaccine experiences, it is reasonable to assume that a vaccine which provides initially 93%, will still be effective more than 50% in the coming years. I think that's a really reasonable assumption. But the important thing here for us is that we follow up, that we check over time. And every country that rolls out a vaccine should also have a program where the vaccinated people are followed. First, for safety, because we have to continuously to make sure that there are no adverse events associated with the vaccine. And secondly, to see how long the protection holds. As you say, we give a booster now. We give a first dose, a second dose. The second dose is a booster. When do we need another booster? Is this something that we can do after a year? Or if this problem with the variant strains and escape mutants, is there a need to do a booster, an annual booster with a variation like we do with influenza vaccines? These are all possibilities, but I don't have an answer, and I don't think anybody has and knows at the moment what is going to happen, how long it takes until protection is waning. But I would like to repeat that if you only use a single dose, you can be sure that the protection is much faster waning, and you need a booster, basically. So that's part one. And then the second part that you asked me, what happens with mixed vaccines? And the vaccine developer are really allergic to the idea that you mix vaccines, because they say, look, we have evaluated our vaccines and made our estimates. We have made our vaccine dossier based on the same vaccine, and this is what we know. We have no idea what happens if you now start mixing antigens, if you first use one and then the other. So the recommendation, and I think people should follow this recommendation, is to use the same vaccine. On the other hand side, if you are sitting in an office and people are coming back for their second dose, and you have no longer that vaccine that you had first, but you have a similar vaccine, a similar platform. Say, for example, you had first one mRNA vaccine dose, and then you have the different vaccines. So first you got Pfizer, now you have Moderna sitting there. It would make sense for me to say, well, let's be pragmatic and just use the other one. If the other vaccine is from a different platform, so for example, you got first an mRNA vaccine and then a vector vaccine, this gets a little bit more complicated. If you had first an mRNA vaccine and then you want one of the Chinese killed vaccines, it gets even more complicated. So I think people have to improvise a little bit and have the opportunity to think about and make their own decisions, for sure. But the recommendation should be use the same vaccine for the first and the second dose.
And what about people who feel just very nervous? As you said, these vaccines have been developed in record time. They've gone through really accelerated trial stages. Even people who are not vaccine skeptics are likely to as somebody approaches them with the needle, just to think, my God, should I be putting this inside me? Is there a fair way to evaluate that?
The safety of the vaccine is what you're asking?
Mm.
Well, I think it should be an ongoing process. So usually what happens after the phase 3 trials, there should be pharmacovigilance in the coming years, so that you continuously monitor if there are adverse events associated, adverse events reported, and there have to be databases for that. So our way to capture data has so much improved over the last 50 years that it would be really possible now to be everybody who is vaccinated to capture that person and then follow up if that person has either develops COVID disease or develops severe adverse events. And then we are starting to get worried if we see something which is an unusual medical event following a vaccination, and then that happens in multiple people following the vaccination. And this sounds very easy if I say this now, but in reality it's much more difficult, because rare adverse events also happen in people who are not vaccinated. So ideally you would have one cohort of people who are vaccinated and one who are not vaccinated. That is really important to do this pharmacovigilance in a reasonable way and to be able to give the answers to the questions that you are having, that you are asking. So that is something that we have to work on.
I've got one more question. I've got one more question here for excuse me, I'm knocking my laptop here, making myself wobbly. For Dr. Nakorn, based on the Thai situation, relating, a lot of our members are of course, foreigners, expatriates. One person has asked, what is the Thai government's policy towards vaccinating the foreign population here. If you consider migrant workers, expatriates, their dependents, it's quite a sizable chunk of the population. What is your view about how the government should approach vaccinating them?
Actually, we have put a prioritized group of people to be vaccinated. When we put a prioritized group, it doesn't mean that we will leave the rest of the group of the people. So by the announcement of the Ministry of Public Health that the prioritized group will be like the frontline healthcare worker, the elderly, the comorbidities group, and the kind of frontline officer over there, like the people who are conducting disease prevention and control, even not in a hospital, like our village health volunteers over there, or the soldier and the police at the border, which have a high incidence of the disease over there. So the rest of the group will be vaccinated respectively when we have more doses, and the doses will come. I can tell you that because the government will secure more doses, but with the vaccine supply for the moment is limited, and we believe that by the end of the year the supply will be more and more, and then by the strategy of we increase kind of secure more dose from time to time so that we can vaccinate the people as much as possible in 1 year to reach the herd immunity level of the vaccine. So aiming for 50% is just only in this year. If we can find more doses, we can vaccinate more people. So we will not leave anyone behind. All of the people will be vaccinated according to the prioritized group. So it will not be excluded. For the migrant worker especially, there is the discussion how to find the other source of funding to cover those migrant workers, which mostly are the undocumented migrant workers, higher than the number of documented migrant workers. So we would need the external source of funding, like from the developmental partners. So we are working on that. So meaning that Thai government will not exclude anyone to be vaccinated. This is the policy, but it will be in a prioritized because the vaccine will come lot by lot. So the people to be vaccinated should be vaccinated in a very strategical way that try to get the most benefit of vaccination, so that we point down to vaccinate the first group on the healthcare worker, the front lines, the elderly, the comorbidities group, and the rest of the group of the people will be vaccinated respectively.
And what's the government's view on private hospitals, for example, bringing in their own supplies of, for example, the Pfizer or Moderna vaccines, which the Thai government itself at the moment is well, I know you're negotiating, but you don't have supplies. But if the private hospitals want to bring it in, what do they have to do?
We did not put any barrier to that. We open for the private sector to import the vaccine. But the misunderstanding is about the like seems to be that anyone can buy the vaccine for at present. If you would like to get the vaccine, you would need a local distributor that have a business on importation of medicine and vaccine, and put the registration to Thai FDA, and then they can import the vaccine. Meaning that the one single hospital, they cannot import the vaccine by themselves. You see the point?
They have to go through the FDA.
The private hospital, they need to buy from the local agency for that particular vaccine. Let's say that, for example, Pfizer, they have their Pfizer Thailand company, meaning that Pfizer Thailand can bring the vaccine, and put the registration to Thai FDA and sell to the private market. You do see that point?
Yeah.
So it doesn't mean that the private hospital import the vaccine and use themselves. So that's impossible for the law and regulations.
Sure.
So you need a local distributor or what we call the authorized representative of that particular manufacturer. Like right now, we don't have authorized representative of Moderna vaccine. So there should be one. So anyone that would like to import the vaccine to Thailand for the Moderna vaccine, they need to be the authorized representative of Moderna to put the registration of the vaccine on behalf of Moderna. And then they can sell the vaccine in the private sector. So that's the step. So that's the misunderstanding during the kind of urgent need of the vaccine and brought the kind of misunderstanding that anyone can import the vaccine like picking up in your suitcase and bring the vaccine to be vaccinated for the people. So that's not the case in Thailand.
Can I just quickly ask you, as you're here, for your own assessment of the COVID-19 situation now in Thailand? We've had a lot more cases in the last 3 weeks, daily cases, new infections, than we saw in the peak last year. And yet the government's being a bit less restrictive in its measures. And as far as I can see, the population is a bit less panicked than last year, even though the numbers are higher. It's quite hard to make an assessment. Do you feel that the measures that are being taken at the moment have a good chance of getting this particular outbreak under control in the same way that Thailand was so successful in doing last year?
I think the situation demonstrates itself. We need to look at the situation. And I think even you don't see any panic, but we've got a very good cooperation from the people. Still be the same. The panic come from the kind of the people cannot understand the situation well. Meaning that we pass that situation and we know how can we behave or practice ourselves. We have a survey on using of masks and hand washing, and we see an increasing of awareness and using masks in the public. So even you did not see any panic, but we've got a very good cooperation from the people. Still be the same. So we believe that our prevention and control measure will have be effective. The time to control of this second wave may be more. We can accept this thing because the situation is larger than the first wave in last year. So it may take a longer time to control the situation to be subside or calm down into below 10 of local transmission. But the number tells itself, and you can see that the number of new cases almost the same for 2 weeks already if you look at the statistic. But it doesn't mean that we can be happy by that number. So that's why I said that the situation will tell itself. So we can look at that. The prevention and control measure that we are doing now, as even you say that it's not like a more restriction like previous time. But who knows? It's a kind of titration of prevention and control measure by the situation of the pandemic. This is our new experience. We need to optimize a prevention and control measure by the time. So this is a way that we are doing now. it's not the way that if we can we put a lockdown and then we put a very restrict measure over there. It doesn't mean that we should took that measure at the same time. Who There is no one who knows the situation well, because everyone is a new experience, and the
Can I just
measure.
confirm on the point we were talking earlier about? So you were talking earlier about the vaccines for plan now to get funding for vaccines for migrant workers. Would that then be a plan for them to get vaccines and not have to pay for them, to get them for free, or try to get funding to ensure that? Is that what you have in mind?
If you got the funding, it can be free for them. But if it's not, we need to find the other financial mechanism within our country to look at the kind of the private industrial partner that they would like to pay for the migrant worker. So we have a way on the financing mechanism to find a way for the migrant worker over here in Thailand. So it's being discussed because it's a dynamic situation, and we hope that we can manage it.
Thank you very much. Lawrence, before we wrap up, I had one question written down here, which is what we hear a great deal from, I suppose you could say, skeptics. Someone's suggesting, is it a viable strategy just to aim to vaccinate the vulnerable, the people and frontline healthcare workers and the elderly who really suffer, and to leave the rest of the population who don't generally suffer very severe effects of COVID-19 as a very low priority and not worry about them? And somebody's actually asked that, do we need to vaccinate everybody?
You protect the people that you're vaccinating. So it's good for the people who are at high risk. And I think it's a great idea to start with this idea. But you're not going to do anything for transmission if you do that. So the rest of the people have still the same risk. That is the outcome of this strategy. Times have changed, and now people are much more skeptical about vaccines than they were 50 years ago. And I don't think it's possible any longer to tell people, look, you have to come and you have to do this, because people just don't follow these suggestions anymore. And now we are living with social media, which also changes the rules completely. And so you see something on your social media and you think, should I really get vaccinated? And that cannot be controlled. But on the other hand side, our fear that a lot of Facebook comments would come up with people reporting that they have terrible consequences from their vaccination has not happened in these 9 million people who have been vaccinated in the United States. Of course, it happens every so often, but it hasn't had an overwhelming effect that it would have stopped the rollout of the vaccines. So that seems to be working, at least.
I mean, you've given us quite a sobering assessment of the potential impact of vaccines, given that a lot of them have only got perhaps 50-60% efficacy, that you'll need to maintain it, that realistically, if you're not going to vaccinate children, you've already left a quarter of the population out. I mean, from what you've said, it suggests that vaccines on their own simply cannot contain this pandemic. Could there be developments in the vaccines over the next year or two? Will they get better? Will we see, from all the research that's been done, significant improvements that might get us to a stage where a vaccine, in the same way that the smallpox vaccine did, could actually more or less eradicate the disease?
What I hope is going to happen is that we're driving the transmission already down with the measures that Dr. Nakorn mentioned, the interventions like masks, social distancing, etc. And that brings the transmission down to a very low level. And then on top of it, we use the vaccine, and that interrupts it. When I was referring to these coverage rate, that means if you only use vaccination and forget about all the other measures that we are using, then you need this really high coverage. But I think if everything is having in an orchestrated way together, masks, social distancing, reasonable behavior, etc., checking and testing and screening, quarantining people who have tested positive. That brings the transmission down to a very low level. Then on top of it, you vaccinate people. And I think that could be sufficient to interrupt transmission for a sufficient long time that you can really eliminate it, until the point comes when somebody imports it again. And that brings me back to the point that it is so important to vaccinate everybody globally and not leave out reservoirs in countries, whether it is in Asia, South America, or Africa. It's really important that everybody is vaccinated and protected at some stage. The sooner, the better.
And finally, Dr. Nakhon, I think a lot of people watching Thailand now will feel sorry that the fantastic record you had last year is not quite so good now. Were you surprised to see another outbreak? The way we saw this happen after the one in Samut Sakhon, and do you think the Thai public have perhaps become a bit more realistic about this vaccine? I know they were very, very nervous about it at the start, which helped in terms of public compliance with measures. But do you think people in Thailand now realize you can't completely keep this vaccine out, that we have to live with it?
I think it's a time for learning it, and we cannot quarantine on the kind of saying by that the outbreak will not occur anymore, because by the nature of the disease, until we get a good coverage of vaccine together with the control measure, so that we can, by that time we can guarantee that there will not be any outbreak anymore. But for now, the people should learn from this. If we look at the cause of the outbreak, it came from the careless, a small group of people doing the unpleasant behavior, like into the gambler, including the kind of a group of importation of the undocumented migrants, or even the import of the undocumented migrant into the country. So those are the cause of the second wave of the outbreak. So we need to look at that, and we need to realize and learn from that. And the government agency, including the people in Thailand, we should work together to control the outbreak and prevent the potential outbreak, additional potential outbreak in the country. I think we will be able to control this second wave, and if we've got a vaccine in time and we vaccinate the vulnerable group, especially the healthcare worker and the elderly and the comorbidities. So we will see that the severity of COVID-19 will be down, will be really low. The case mortality rate, what we call the case fatality rate, will be less than 1%, and then it will come down to 0.8, 0.5. So if we can vaccinate the vulnerable group in a good coverage, which is maybe only 20% or 30% of population of Thailand, so the severity and the panic of the disease will come down, and we will be a kind of relaxing something on the measure, or release on the strict restriction of the measure. So our life will come to be a kind of, I use the term of near normal, but not the normal before the COVID-19 outbreak. It will be like a near normal. So meaning that we should keep something good that can control the outbreak until we've got the control of the pandemic globally, so that that we can be sure of the safety of the people, and hopefully that the vaccine can be the additional measure that can work on that way, and then we can control the outbreak. I think in next year, I think we will see the good result of control measure together with the vaccine. Over.
Thank you very much indeed. With that, I'm going to wrap up this fantastic discussion with with Dr. Nakon Bremsi and Dr. Lawrence von Seidlein. We learned a great deal. Thank you. It was very, very informative. Thank you to all of you who've joined us for this online discussion at the Foreign Correspondents Club. Do join us. We've got another discussion on the explosion of investment in cryptocurrencies and Bitcoin coming up on the 27th of January, so look out for that. In the meantime, this program for tonight we will put up on our YouTube channel, so you will be able to access it again anytime in the future and have a look at these comments. But to both my distinguished guests, a very warm thank you from me, Jonathan Head, to all of you. Good night.
Bye.